Welcome to the Black Trust Podcast. As I sit down for a conversation with Philadelphia surgeon Dr. John Cruz, Medicaid cuts and medical facility closures are rampant in economically distressed Black communities. This is part and parcel of the cascading consequences of the budget reconciliation bill passed in July 2025, which will cut $890 billion from Medicaid over 10 years. The legislation's Medicaid cuts threaten healthcare access for millions of Americans and allows the Affordable Care Act tax credits to expire. Specifically, it's estimated it would cause 4.2 million Americans to lose their insurance over 10 years. The remaining insured would see their premiums rise dramatically. The bill also includes cuts to Medicare provider payments. It's been 50 years since the Civil Rights Act and the creation of Medicare, which ostensibly eliminated hospital segregation. Yet hospital systems remain segregated by race in practice. The most inclusive hospitals in the country are Safety Net and public hospitals which serve Black communities and are severely under-resourced. This, of course, leads to poor quality of care. Numerous studies document that inclusive hospitals that serve the greatest proportion of Black patients simply get paid less per patient, due in large part to differences in private insurance coverage or the ability to pay. White patients are disproportionately more likely than Black patients to have employer-sponsored insurance, which pay higher rates than Medicare or Medicaid. The pay-for-performance model means that higher payments, more resourced hospitals, translates directly into better quality care, better patient outcomes, and lower mortality rates for whites. When hospitals serving Black communities are under constant financial stress, improving the quality of care is a perpetual uphill battle. In some cases, hospitals have to close, such as Hahnemann University Hospital in Philadelphia, and most recently, right where we're located in Delaware County, Pennsylvania, the Crozier Medical Center shuttered in May of this year, 2025. Devastating the surrounding communities. The stratified American health insurance system continues to assign a lower dollar value to the care of Black patients. Welcome, greetings. I am pleased today to be able to welcome Dr. John Cruz to our podcast. Dr. Cruz is a surgeon who is an ardent men's health advocate who practices in Philadelphia. Welcome, John.
Thank you for having me.
How do you see the accelerated closure of lots of medical facilities in Black communities and poor communities, the slashing of SNAP funds that's going to be for at least another decade, if in the legislation that has just been passed, as we touched on earlier, the defunding of higher education that hits HBCUs and cancer research, which of course our African American rates are some twice as bad as the mainstream in practically every health condition. So research funding, training funding, SNAP benefits, closure of medical institutions, medical institutions and facilities, hospitals. How are you going to see that in your practice? How is that going to impact you as a physician and the people coming in to see you?
We're going to see more of what we call acute care. When you don't have emergency rooms available, emergency access, primary care and holistic doctors who are interested in holistic medicine see a lot more primary care type of issues. So it's nothing for my patient. For example, I may be checking on them for something surgical. However, they say, look, can you refill my blood pressure medication? Oh, well, you can't go see your doctor. Well, my doctor I have to wait a certain amount of time, or it's going to cost me this copay, and I'm here already. Can you do this for me this one time?
Mhm.
So you're going to see a lot of,
In that instance, do you do it?
it depends on the situation. If it might depends on my relationship with the patient, and also do I know their particular physician? Because there's some physicians, primary care physicians, that are better than others. So if I feel like I can do just as good a job as your primary care physician, I might I might fill in for them.
So
Yeah.
it's a very individual, subjective thing. And if the medical facility in that person's town was just closed and they do have to travel an hour out of their way and don't have consistent transportation, I would assume you're more, I don't want to assume.
Yeah, yeah,
I would
you're
think you're more
exactly.
likely to do it because
I'm
they,
more likely to do it. Absolutely, I'm more likely to do it. Or if someone, for example, there sometimes mental health is very hard to access. And in Philadelphia, you can't just send someone to Friends Hospital. They're not going to take everybody. So sometimes you have to weigh the odds of helping somebody for a month until they can actually get to a facility where they can get the help they need. So that
you
this
do
is really,
you do that bridging process knowing their circumstance and the circumstance where you're
yes.
practicing.
Yeah. So you're going to see a lot more of that, or else it's going to get chaotic before it gets better. And I think what will happen is practitioners like we're doing now are going to start talking more and come up with more doctor-centered entities to, because right now everything is being run by business people and bureaucrats. Um, that's probably why the system has failed in
Do
many
you
ways.
feel like you've got this layer, the business people and the bureaucrats just kind of s- have you in a vice or kind of sitting on your head or keeping you constrained? It when you the way you speak, it sounds like you don't have a lot of choice in this model.
You don't. I'll give you an example. When we first came out with electronic medical records, most physicians, especially if you were older than 50, were rebellious against adopting these records because it actually took you more time to do the records than it did to see the patient. And I would venture to say in some hospitals it's the same way.
Sure.
So it's going to be it's going to be rough. It's going to be rough for a while.
Did everyone adjust to that? And now the normal
It's normal.
basically is you spend more time with the records and the patient.
Yes.
What are you observing in terms of quality of care, in terms of patient outcomes, patient satisfaction, um, patient trust in the medical system? That is a vast area,
I
quality of
would
care.
I would say outcomes are definitely better in terms of hospitals, but patient satisfaction is not. But hospital outcomes are better just
Yeah, that's
because.
isn't it? You get you have a better outcome, but you're miserable in
Correct.
the relationship with your physician.
Exactly. And of course, the pandemic made trust a lot worse because of fear of spreading infection. We as physicians stop communicating with the families. I mean, you may know someone who's lost a family member, and then they found out the cause at when it came time to sign the death certificate. I mean, the patient was dying, and there was one contact person, and then before anybody could see the patient, they were had already expired.
Talk about the before. What does before look like? You just talked about what happened during the pandemic and how have people throttled back from that and tried to reconnect with families at this point? Or is the momentum such that, okay, we don't have to do this, waste that time. We're not going to go there. What did before the pandemic look like?
Well, before the pandemic, there typically at most hospitals there is a head nurse and then what we call an attending physician. That attending is the person who is in charge of your care.
Mhm.
So take an example. Let's say you were to get shot. Okay. You were in the street, got shot, you went to the hospital, your surgeon, repaired the injury, you went to the intensive care unit. there's that surgeon is in charge of all of your care. Let's say you broke a leg in the process of getting shot in the leg. There may be an orthopedic surgeon on the case as well, but there's one designated person. That one designated person is responsible for communicating to your proxy, your family. And then that doctor may or may not say, look, if there's more family members that need clarification, call me, or call my colleague will take over on the next shift.
Okay.
And then at the final day, the person's going home, that doctor typically communicates with the family one more time to tell them what the plan will be when they come back to get their wounds checked out, to get their staples removed, so forth and so on.
Okay.
That was a process that was totally abandoned during the pandemic. Yeah.
So people simply, as you said, simply did not know until the death certificate actually stated what the problem was.
Right.
Okay, where are we now?
Where are we now is we're kind of almost caught up. The problem is now we've entered a whole new phase of telemedicine, because telemedicine was designed, it became kind of new during the pandemic, because now I can still generate income while I can't go outside.
I don't have to move.
Right.
I can put on my lab coat and my pajamas and be
a doctor. So now we're at the point where, okay, I've been going along not having to communicate with people, but now people are being empowered because now they're demanding clarification. And it's so difficult because if you've ever gone to like an insurance website, you'll see that the insurance company wants to try to answer as many questions as they can on their website because they know the doctors
want to talk to you.
Right. So you go on this website, it's like, wow, I just want to, pay my bill, and you'll see all these other things, customer satisfaction. I mean, just amazing surveys. So we're at a point where we're kind of trickling back to that nobility that we try to get.
Why are people becoming more demanding at this point?
Because of inflation. Things cost.
It basically, the pocketbook gets hit.
Yes.
I'm going to make sure I get my money's worth out of this guy.
Exactly. Yeah, inflation.
And are the physicians responding in kind, or they continue to back up and rather not talk to people and just put things on websites?
So there's three types. That's a great question. There's three types of physicians. There's physicians who proactively manage their online profile, meaning their satisfaction, the little stars you put, oh, Dr. So-and-so was so wonderful. Most physicians will tell you that if they don't manage their online profile, it will be inundated with people who got rescheduled, couldn't be seen, we didn't take their insurance, and then they'll put a negative post. And now you have this wonderful doctor who has a 3-star, 2.5-star rating, but his 80% of his patients that were very happy never went online. So now you have doctors that have computers in their office. Then there's doctors who have humongous practices, could almost run for city office, public office, and they just don't care. Like, they don't care about the internet. They don't care about Google.
Okay, drill down into this kind of physician, humongous practices. What does patient care look like when someone has quadrillion patients?
So that physician either becomes someone who is very savvy at seeing the patient in the office, giving the patient their email or cell phone number. I've heard more and more that I have my doctor's cell phone number. That was something you never heard of 10 years ago. And even now, there's certain patients who have my cell phone number, but then there are certain patients I would never give my cell phone. because
And
they
then there's the cell phone that you actually have for the patients, and then there's your real cell phone number.
right. Yeah, Google Voice is a very good tool, but also email. There are patients who, rather than talk for example, let's say you just had your hernia surgery done, as opposed to be sitting in the office giving you all of these different exercises you can do versus ones that you can't do. I will send you a YouTube video when I get back to the computer at night. Now you can see, and guess what? I can even tailor that video to race. So I can make it so that if you're overweight, I can send you an overweight person doing exercise.
Are you taping these videos yourself, or
No,
this is just something you find online that's
yeah,
works?
you can literally, put an African American riding exercise bike on YouTube and you'll get close. You may not get exactly what you want, but you'll get close. You can put on there, teenage child meditates for the first time. So now somebody who you think meditation might be good to start off 5-10 minutes a day, now they have it in their email. And guess what? Now they can show their friends. So we have to become more skilled at office time management. And it's actually a little bit more beneficial sometimes.
So that you give them more resources that are online, tech savvy types of things to
Right.
compensate for the fact that you've got quadrillion patients that are only going to get in there for 10 to 15 to 20 minutes. So you need to give them all of these resources to provide some
Right.
adjunct to the short period of time they actually see you. Now, what's the third category of doctor?
The third category of doctor is the doctor who um, looks worse than their patients. Meaning that the doctor that my gosh, you're gonna tell me how to lose weight and you look horrible. Your hair is disheveled, you
I'm
got
sorry.
coffee stains in your shirt. That sometimes is the doctor who cares the most about their patients because they're devoted their entire life to their patients. And I mean, literally, they're with on their patients all day long. They give their patients more than 15 minutes, and that person has just been destroyed because they're really holding true to their profession, except when it comes to self.
When it comes to themselves, they may have a stroke before the patient does.
Right. And I make the comparison. We have a new heavyweight champion of the world. Okay. Not heavyweight. Well, he's the pound per pound best fighter, Terrence Crawford. He just won 2 weekends ago. If you look at his trainer is over 400 pounds.
Oh, good
Okay.
Lord.
His trainer has been with him since the start of his career. So one might say, well, how can the best fighter in the world have a trainer that out of shape, that unhealthy? I mean, this guy can, barely walk 10 feet, but he knows boxing. He knows boxing. He knows the science of boxing, and he's passed it on to his student.
Wouldn't it be nice if there was some congruence between the two things? One's
Yes.
expertise, one's dedication, and one's sense of self? You talked about stress and being aware of all the stressors that the patient is under. For example, in eating and the type of eating, comfort eating, type 2 diabetes, sugar spikes, etc. Do you have the time to really suss out what the stressors are? As a holistic practitioner, I have an hour and a half with someone for my intake. And
Mhm.
every time I see them after that, it's an hour. Do you have the time, if you're not seeing them consistently and you're only get that 20 minutes, to know what those stressors are? And then could you relate that to weathering and the impact in our community of chronic, incessant racism on health outcomes that is directly a function of heightened stress, cortisol levels racing through people's systems at all times because we're always watching our back?
So I give the patient kind of some data for ammunition without providing direct solutions. So I tell them that, all right, if you compare a black woman to a white woman. I think the last I checked, there was a 6-year difference in longevity. Okay. And if you know that weathering definitely affects your health, overall health, then how do you counteract that? So we have to then talk about drinking and smoking. So I explained to them, if you make the choice to drink and smoke, your life is definitely going to be shortened. But you can counteract some of this by cutting back on your drinking. I think women, it's 1 drink a day. Men, it's 2 drinks a day. Cigarette smoking, 1 to 2 packs a day shortens your lifespan. Okay. And then we have to talk about, if you're not going to change any of these habits, where are we going to go from there? That's when I got to get the person to see someone like yourself. Okay. Because they have to have it reinforced.
Well, here's the thing. We can be, as we know with infant mortality, women's outcomes at maternal mortality, really, for Black women. I think that's where it's been studied most extensively. You can be a PhD living in a McMansion someplace, going to farmer's market for your organic food, seeing a doctor regularly, meditating, doing your yoga. Black woman basically living the life. Weathering is still impacting her, shortening her life, because it's a function of being Black in the United States, irrespective, regardless of socioeconomic status, educational background. What do we do with that, Dr. Cruz?
Well, I take it back to history, because while we know that these issues are American issues, once we have a world view of suffering, I think it really makes that weathering effect not have so much burden on you.
What I think I'm hearing is being able to step back into metacognitive position and to be able to see the state of being minority in the United States.
Right.
And not be pulled down the rabbit hole of the emotional response and the reactionary response to the level of microaggressions or whatever you're dealing with, whether you're a PhD or haven't come out of high school. It's being able to see it for what it is, so at least some of it rolls off. Is that where you're going with this?
Exactly. Because again, it's going to be through networks that people get healed, not from a solo practitioner.